City Health and Hospitals Finance Committee. Today's meeting is officially called to order. According to the bylaw, Section 14, committee attendance. If any member of a standing or special committee of the board will not be present at a scheduled committee meeting, the member may ask the chair of the board to request that another board member, not a member of that committee, attend the scheduled meeting and be counted as a member for purposes of quorum and voting. Therefore, Jose Pagan has authorized Ann Williams Isom, represented here by Erin Kelly, be counted for the purposes of quorum and for voting on Jose's behalf. I would like to propose a motion first to adopt the minutes of the Finance Committee meeting held on July 1, 2024. Do I have a second?
Second.
I will poll each member. Dr. Katz?
Yes.
Sally Hernandez-Pinheiro?
Yes.
Erin Kelly?
Yes.
I vote yes, and the minutes are adopted. And I am going to step out and recuse myself for the two resolutions.
Okay, thank you so much, Frida. Okay, we have two resolutions for consideration. Linda, would you please read the resolutions and proceed with the presentations?
First is authorizing the New York City Health and Hospitals Corporation, the system, to execute an agreement with PFM Financial Advisors, LLC for the provision of independent registered municipal advisor services on behalf of the system for an initial period of 3 years and 2 one-year renewal options exercisable at the discretion of the system for an amount not to exceed $1.125 million. And this RFP is, as we said, for financial advisor services or municipal advisors services, which provide us with the expertise and resources that assist us in developing and executing debt finance strategies and other related financing functions. We are for this contract a not to exceed amount of $225,000 per year, which will be capped at a lower amount during years where financing does not take place. As noted, municipal advisor services, formerly referred to as financial advisor services, our last solicitation for this service was in 2017. PFM, which is selected here, was our incumbent vendor and has been serving in this role since 2002. Their previous contract awarded in 2017 included a $170,000 per year, not to exceed to amount, but total spent to date is just under $125,000. For this RFP, we established a minimum criteria of 5 years experience with public finance advisory services, 5 years of experience advising public or voluntary hospitals and or other healthcare institutions in debt financing and other financing alternatives, and advising on at least $500 million worth of municipal or healthcare bond deals in New York State in the past 5 years. The criteria for evaluating proposals was 40% based on vendor experience, 35% based on the ability and feasibility of their proposal to meet the scope of work, 15% on cost, and 10% for MWBE status. The committee included representatives from our corporate debt finance department, our corporate controllers department, the New York City Office of Management Budget, and the New York City Office of the Controller. The RFP was issued in June of this year, posted on City Record. We had 11 vendors who received the materials. 2 attended a pre-proposal conference call, and those 2 submitted proposals. Final scoring was done in August of this year, and PFM was the top scorer. This is the scoring of PFM's previous performance, which has been satisfactory or actually very good for the entire run of their term with us. We want to note that this procurement falls under OP 4055, which governs debt finance and treasury operations rather than the broader OP 100-05 for procurement, and therefore doesn't have a particular diversity policy attached to it. However, we did follow the OP 100-5 review process and had the vendor diversity team review the scope of work under this solicitation. They found no subcontracting opportunities, and as the vendors self-perform all of the work, Therefore, no goal was set. We did also, through that team, identify 4 MWBEs that were invited to respond, and none of them chose to apply. So again, the request is to authorize execution of an agreement with PFM Financial Advisors for independent registered municipal advisor services on the behalf of the system for a period of 3 years and 2 one-year renewal options exercisable at our discretion for an amount not to exceed $1.125 million. I'm happy to take any questions.
And just, could you very briefly discuss some of the services that PFM has provided to you and that you look forward to them providing with this next new contract?
Yeah, I mean, they're really sort of our eyes and ears in the marketplace by nature of their broad experience. They are able to assess current market conditions, advise us on new financing strategies. They work hand in hand with us in any financing effort, sort of as an independent counterpoint to our bankers and the rest of the team that we're working with. They help us with pricing when we do any financing. If we're doing something outside of the bond market, they may sort of survey the market and actual institutions for interest in what we are proposing. They help us in any discussions with rating agencies. They keep us, advised of what's going on. We found them to be quite valuable, and we really think that they have improved our performance in all of our financing activities.
Okay, thank you very much.
Okay, any other questions? Okay, very good. Then I'm going to poll our members for a vote. Sally?
Yes.
Aaron?
Yes.
And I vote yes, so it's approved. Okay, Linda, I believe you have one more resolution, please?
Yes. This is authorizing the New York City Health and Hospitals Corporation, the system, to approve and appoint 22 firms to provide bond underwriting services. Of the 22 firms, 5 will be approved to provide investment banking services and serve as senior managing underwriters, and 17 firms will be approved to serve as co-managing underwriters as designated on Exhibit A in this deck. Services will be provided on behalf of the system for a 5-year period. A not-to-exceed amount was not established for this RFP. And the reason that we don't establish a not-to-exceed amount here is that this is not a contractual arrangement. It's identification of a qualified pool that we will work with in the event of any financing. We come back to the board for specific approval of our financing, and included in that approval is the authorization to enter an agreement with a senior underwriter who then would work with the co-managing underwriters. And in that board resolution, we would present a proposed plan of finance, including potential fees. So again, this is for a pool of qualified firms that will serve as senior managing or co-managing underwriters related to future debt. We last solicited for a qualified pool in 2015. Through that 2015 RFP, we selected 3 vendors to serve as senior managers and 17 vendors to serve as co-managing underwriters. And we've discussed the lack of a not-to-exceed amount. So a little bit about what these services are. We use the senior managing underwriters to assist in the development and structuring of specific financing plans, market strategies, approach for debt issuances to ensure successful underwriting and marketing. And they are actually sort of managing the sale of bonds that we issue. Co-managers will support marketing and distribution efforts related to those debt issuance based on existing market conditions. The bond underwriters may also commit capital to our bond sales to provide support and provide support in the secondary market, both of those on an as-needed basis. Selection of the pool through this RFP was based on companies' ability to provide us with the highest quality financial market strategy and services. And again, appointment to the pool does not guarantee participation in any particular bond issuance, and we would come to the board for approval of any specific bond issuance. The RFQ criteria here was that for senior managers, they must have a minimum of 5 years' experience as a senior managing underwriter of municipal bonds and must have managed at least $1 billion of municipal and/or healthcare bond deals in the previous 3 years. For co-managers, the firms had to have at least 3 years of experience in underwriting municipal bonds. And the firm or the key staff on the assignment must be licensed by FINRA. For our evaluation committee, we included, again, members of our debt finance team, our corporate controller's office, the city office of management and budget, and the city controller's office. The criteria for evaluating proposals was 50% on vendor experience, 40% on the ability and feasibility of their proposal to meet the scope of work, and 10% for MWBE status. We issued the RFP in June of 2024, through City Record, had 31 vendors receiving the materials. We held a pre-proposal conference in July, which 18 vendors attended, and we received 22 proposal submissions. The evaluation committee final scores resulted in selection of top 5 proposers for senior manager. This is an expansion from 3 in our previous RFP. And we selected, we approved all other respondents to be part of the co-managing pool, thinking that there is an advantage to having a larger pool. Will give us more flexibility going forward. For all vendors who had not worked with us previously, we conducted reference checks, and for those who worked with us previously, they have all scored satisfactory or better on evaluation. This, again, falls under, like the previous proposal, falls under OP 40-58 for Treasury and Debt Finance. But we similarly had a review by the procurement team, vendor diversity team, as part of our regular procurement process. They found that there was no subcontracting opportunity here, as well as this is all work performed directly by the vendor, and there was no goal set. We did, however, have good MWBE representation in our selections. We have one senior manager firm of the 5 is a certified Hispanic MWBE. I will note this is the first time that we have an MWBE as a senior manager, and 7 of the co-managers are MWBEs. So again, our request to the committee is to authorize the approval and appointment of 22 firms to provide bond underwriting services, 5 approved to provide investment banking services and service senior managing underwriters, and 17 approved to service co-managing underwriters as designated on Exhibit A. Services will be provided on behalf of the system for a 5-year period there is no not to exceed amount. Happy to take any questions on that.
Thanks, Linda. Any questions for Linda?
Just congratulations on having a MWBE firm as a senior manager and having 7 co-managers at MWBEs.
So we're very happy with that.
It's wonderful. Erin, any questions? Okay, then let's vote. Sally?
Yes.
Erin? Yes. And I vote yes, and so it's approved. Thank you so much, Linda.
Thank you.
Okay, Frida is going to come back in, and then we'll be able to continue with our agenda. Welcome back.
Thank you. All righty. Well, thank you. Next on our agenda, we have the financial update from John. You and your team will lead us through.
Yeah, thank you.
Great, thank
for
you.
your time. Yeah, this is just a report on how we finished out FY24. We have a slide in there talking about the FY25 budget, a couple highlights there. I'd say the system performed very well throughout the whole year, but particularly the last quarter. We closed June with $581 million, or 20 days cash on hand. We outperformed the budget by 1%, or almost $180 million. Direct patient care receipts continue to climb, so this is on a year-to-year basis, $321 million. I think we have the purple chart in the package. And as part of FY25, we've set a target for ourselves in the same range for this coming year. I think as we emerge from COVID, things seem to be strong for us. Discharges up 1.2%, outpatient visits up 10.7%. The strategic financial initiatives, again, we continue to perform very well there in all the sectors that we designated as room for improved performance.
John, I
Yeah.
just wanted to
Yeah.
note, because people may not remember, that prior to COVID, the trend in our patient care volume was down. So it's not just that it's up, it's that we actually changed the direction,
Yes.
which is quite impressive.
Yes, thank you. Yes, very much a full team effort on all of that. So our cash position looks good. I think we have $800 million in the bank today, closed September 6/15, expected to close October with $600 million. The next slide here is just always going back and taking a look in terms of where we've been. I think anybody got the clicker?
Yeah.
So this is a version of a slide that we present to the CEOs when we wrap up the FY25 budget. They all come in, they talk about their plans. It's actually a very nice meeting. But here, we can see a lot of what our success is focused around execution and executing on the budget. So we've talked a lot about the recertification of Medicaid eligibles. We did 2% better than our target there. The Metro Plus and Health First enrollment is incredibly high at this point with 603 and 161,000 respectively. The risk pool performance, continues to, help us immensely. It helped us through COVID, that guaranteed, payment structure where we get paid a fixed amount, for each recipient. The pools hit a historical amount of $889 million, and our PMPM performance, I think, is very significant at $75 per member. The glide path, when we were here last year, we spoke a lot about, the financial pressures that was placed on our budget as a result of, contract nurses. We called all hands on deck, and really quite remarkably, the leadership of, Yvette and Natalia, and really the whole, HR and nursing team. We now have 1,600 or 1,660 RNs that weren't with us at this point last year, and that's really quite remarkable. That was $100 million in savings against the budget through that effort. We took a hit from Change Healthcare. We feel like we've pretty much fully recovered from all of that. We want to thank our friends at the state. We've had to go back to them a number of times, asking them to keep the door open to allow us to resubmit and get an accounting of our remits, and that's been very helpful for us. NYC Care enrollment, right, is 125,000 members. That allows our patients to have a clinic and a doctor they can call their own. We feel very good about that. We're testing out what we call the one-stop benefits. Perhaps we can talk about that a little bit more later, but the idea here is our patients are coming in to get recertified. We're enrolled with Margie and Allison's financial counselors. We're also exploring other welfare benefits that they would be eligible for. So we have that launched, and we're excited about advancing that, to more of our patients. And then we also had a $90 million target that we asked our facilities to deliver on. They achieved $81 million, and that, in my mind, that's just good execution, and they delivered where we asked them to.
This is a
John?
very, go
sorry,
ahead. No,
please.
go, Mitch.
I just wanted to take a minute, it's embedded in this to admire Margie and her team, both for, the continued production of revenue, the general leave no claim, how did you put it?
No claim behind.
No
claim
claim behind, the switch of enrolling people ahead of their visits into insurance and making sure that we had the accurate information, right? I mean, it has produced, Margie, you and your team are really the gas that's keeping, the doctors working and the nurses working and the social workers working, right? Because, without the revenue, we can't do it, It has been such an amazing year-to-year growth, and it's many things, right? But one of the things is recognizing that if people have insurance or are eligible for insurance, we want them on insurance, and we want scarce general fund dollars to care for people who are in NYC Care who don't have any insurance. But if you're eligible or have insurance, we want you to use it so that we have enough money for everybody who doesn't have insurance. And I think you've done a phenomenal job, and I continue to see both year-to-year improvements in the process of getting people through with their coverage ahead of time and noted in Epic, and then just the general revenue dollars keep growing. And again, that's multiple things. It's the financial plans, it's the growth in our services, but being able to bill insurance has been just a huge part of the change. So thank you so much.
Thank you.
Go ahead,
Sally?
Sally.
I just want to note that the 1,660 RNs don't only produce $100 million in savings, which is amazing, but they're our nurses. So we get to train them the way we want them trained, have the kind of vision that we want them to have. So beyond the money, it creates a whole new dynamic in the organization.
Absolutely, right.
And Sally, I've asked Natalia to really track them as a cohort.
Yeah.
And she's already, we're not waiting to the third year, which is what we usually did, to try to retain people. She's doing awards at 1 year, and the whole idea is to track those new nurses and figure out how to keep them. Of course, you'll never keep 100%, but if people are leaving, why are they leaving?
Right.
Right, and being sure that people feel appreciated, and if they're leaving, that they're not leaving because we've in some way been a bad employer, but they're leaving. Sure, you move, you have better opportunity, that's fine, right? But we want to make sure that people are not leaving us to join another system because they felt unappreciated, or that they weren't able to practice the way they wanted to practice nursing. So she's going to follow them as a cohort.
That's great.
Because it's a unique time, right, where we onboarded in a relatively small period of time a large number of nurses, all getting competitive salaries. And so the question should be, we should keep them, right? We want a very high percentage of those nurses at 5
Retained,
years. And so we're going to put a lot of effort into trying to retain them.
That's great. That's a great idea.
Thank you. But I think I'm glad you put this in, John. It's a nice complement to the audit committee discussion we just had on 2024, achieving the results we did there, and putting some context around that, just away from the numbers. So thank you.
Thank you. Managing risk, we just have noted a few here, similar to nursing. We'd like to invite more locums to permanently join our workforce, and we're going to develop some strategies around that. The city, state, and federal budgets are all underway in various timelines, so obviously we have to keep an eye on that activity. And as I had mentioned, Change Healthcare, pretty much all resolved. There's a couple of claims at the very bottom of the barrel that we're not going to give up on.
No claim left behind.
No
right?
claim left behind.
Hi.
So I will give a little more detail into what John mentioned at the start of the presentation. We ended our year-end or June with a positive budget variance of $180 million, which was really good considering a lot of the different factors that impacted our financials this year. Our receipts or revenues came in better than budget by $573 million, primarily driven by risk pool. And this was due to improved per member per month rates and prior year reconciliations. This revenue was able to support our disbursements, where we exceeded budget by $395 million. And some of that is associated with medical and surgical supplies, pharmaceuticals, and taking care of additional patients that came in higher than anticipated, and some temp and other salary coverages. on this slide, this just shows us the breakdown of that budget variance on the revenue side. On our inpatient, outpatient, we just met the target despite some of the cash delays from CHC. And this may be understated as we have more claims that are left behind. But the star of the show is the risk pool performance, which came in at a positive $538 million, ahead of our budget. Some of this is one time, however, the recurring values we're capturing in our fiscal year 25 budget. Other revenue that came in, a surplus for the prior year appeals for Medicare and Medicaid. And so that's the breakdown of the revenue budget, which again, great job on that side. On our expenses, we are 4% over budget. And on our PS, we'll start there, a lot of it is driven by overtime. And so we are rolling out some additional staffing models where they do not exist and looking at existing staffing models to potentially right-size them to reduce the reliance on overtime expenses. On the affiliations, as John noted, we're addressing that through a potential glide path, through a series of an all-hands-on-deck approach to address the sessional and locums usage. And our temps, though they are pretty high, they are a lot lower than where we were at this time last year. They're starting to come down as facilities are hiring up on their nurses, as in accordance with the glide path. And since last quarter, we're looking at our average monthly payments. They've decreased by 45% since the start of the year, and we are expected to continue to decrease as more nurses complete orientation and we're able to roll off the temps. Lastly, we have some overages on our expenses, on our other than personnel expenses associated with volume, also with aging infrastructure and inflation. And some of this we're addressing in our fiscal year budget for 25. And this is the purple chart that shows the year-over-year change in our revenue performance. On our inpatient, outpatient revenue, we are seeing higher actuals in FY24 than in FY23. And again, this is potentially understated due to Change Healthcare. However, compared to the same time last year, our discharges are up by 2%, visits are up by 4%, and our case mix index is slightly higher at 1.3%. And so this is a good news for us as we continue to go into the new year.
And there's no increase in New York City population, right? Just because that could be another reason why your visits are up, but that is not the case. It's clearly that people are choosing us at a higher rate than they once did.
Exactly.
Wonderful.
For the next slide, these now shifting to FY25, some of the keys to success, we mentioned some of these in our last meeting. So basically, we're leveling up even further to Dr. Katz's point earlier with the revenue generation and continuing to push the envelope there with the efficiency also of our strategic services and initiatives at our facilities and across the system. So raising the bar again in managed care and revenue cycle targets, while at the same time targeting our patient access locally. You see that mentioned 3 times. And very critical for this fiscal year, expanding our cross-facility partnership and using those relationships to maximize the services and the availability of services and timely availability to our patients, the physician workforce plan, which is under the affiliate umbrella, making investments there for recruitment, targeting our length of stay, making sure that we are discharging quickly and efficiently in a safe manner, of course, for the patients, and putting some infrastructure investments in place to support the needs and the volume increases across the system, again, in an efficient and effective way to meet our demands by area, and also the continued effort to stabilize our workforce across the system. We talk a lot about our staffing models, and Tasha mentioned earlier, our goal is basically to have a model for the majority of our
For everyone.
staffing needs.
Everyone,
across-
right.
Exactly,
Yeah.
everyone. And it's important to do that so that we can actually have a good measure to really assess where we stand and make sure that we are fully meeting our patient care needs and our facility support and needs across the system. And so to do that effectively, we definitely need the models to continue. Building, again, that's the last one. We're working on the facility side of the world. OFD is a particular focus, which will also help with the overtime that Tasha mentioned earlier, again, to have the right complement of staff.
I think, Micheline, the one thing that's also inherent in all of what you've done, but to make it more explicit for the board, Health and Hospitals historically is a federation of hospitals. And it's a huge challenge, Micheline correctly says, cross-facility partnerships. It's a huge work to make it happen, in part because it's just not the psychology of the organization. It wasn't how the organization was created. And the history of the organization is that each hospital deals with its needs. And we have now had several successes. We have a huge success with radiology, which is now being read in evenings and weekends in a completely consolidated across the organizational way. It's the first because for the radiologists, it doesn't matter where they are. Right,
get the
it's all
image.
IT. Right, they're looking at the image. There are no X-rays to look at anymore. It's all computerized. But it was a lot of work, but it was a huge success, and it decreased our use of overtime at the facilities. And clearly, that is the model that we want. As hard as it wasn't for radiology, it is harder for everything else. But we're working at it.
Yeah.
We're trying to get, especially for evenings and weekends, to try to establish system-wide coverage. And the good thing is, to the extent we succeed, it's not only a savings, but it's better care, because we'll increase access. And we'll be providing it in places where we're not currently able to provide it, right? So for a long time, Queens had no neurology coverage on weekends, which is very common in hospitals. Neurology is a Monday through Friday specialty in most hospitals other than a trauma center. We're now able to provide them virtually neurology coverage on weekends and nights. So we're trying to find the right mix of virtual services, of common call schedules. We're looking at sort of what are the sensible hospitals to work together. For example, Lincoln, Harlem, Met are pretty close together physically, and they are all PAGNI sites for the physicians. So that's a sensible triangle to try out various kinds of let's work together, especially nights and weekends. So if you look at the 3 hospitals, they all have different levels of coverage of maternal fetal medicine. So why wouldn't we have that be a consolidated service of maternal fetal medicine? And the biggest challenge is just the psychology of it. That each time you talk to a doctor, they say, well, I have confidence in my hospital, but I don't know what goes on over there. And so we're trying to work through that. So it's both a financial issue and it's a psychological issue, because you can't save the money if people don't want to do it. You have to conquer first
The
the
culture,
psychology
yeah.
of it, and convince people that this would be better for them, for their patients, and then you'll get the savings and the improved access. But several of the things that Micheline has so well explained, I think really depend on the degree to which we can focus people on, we are Health and Hospitals, we are a system, right? We did it with IT, we did it with the ambulance service, we do it with finance, we do it with personnel. But then everything else
The doctors
tends,
get involved.
the doctors,
Oh, those doctors.
but it's really the whole, it's the fact that if you ask somebody at one of the hospitals where they work, they're not going to say health and hospitals.
Right.
And that's not just the doctors.
No.
Right. They're going to say, I work at Lincoln. And that isn't a bad thing either. Right. We like the idea of people being prideful of where they work. We like the idea that each of the hospitals has its own traditions and culture. We don't want to get in the way, and I don't want carbon copies. I don't think everything has to look like everything else. I just think that we should be further along. If you look at what most hospitals do, right, that are systems, there's one urology service. Right, they take care of all of the urology patients together in all of their facilities. That is not for primary care. Primary care doesn't matter because that's the relationship between the individual person and their doctor. You can have that in as many places as you want. It's really the subspecialty, which is expensive, short, right? Often we can't even hire as many as we would want to. Those are the ones where there's a tremendous benefit if we could get people to say, okay, I'm the MFM service for Health and Hospitals North, right? And I take care of all of the women who need MFM consultations at Lincoln, Met, and Harlem. And that's what we do. So that's another typical, that's how Northwell does it. That's how NYU does it. The MFM, which is a specialty of OBGYN, right? So you have the OB or GYN person at the hospital, that's fine, right? Because they're going to be delivering the baby. But the consultation of, what special things should be done for this woman, that's a specialty service. That should be done in a group practice, because we would get so much more coverage if all the MFMs work together. It's just never been the model of health and hospitals.
But we're working towards it.
We are working towards it, and we have some successes.
Yeah.
I also wanted to give some credit to the work that's being done at the call center, because I think that also helps with keeping patients and bringing in new patients. If you know you're going to be able to get through, get an appointment.
Yes.
And that's a heroic effort that's going on.
Right. We've asked Andrew Wallach to eliminate every other telephone number that a patient would call. Seriously, because the variety of numbers generally don't get answered. And not because it's not because someone is sitting next to the phone and not answering it. It's because there's nobody sitting next to the phone. Right, because we don't have that level of coverage. So, and the numbers change and the staffing changes, and once there was someone there and now there's not anyone there, but no one's changed the numbers, and we're like, stop, just go to send everybody to the call center and then brief the call center on who to call. Right, so that and then with the call center, then we have a log of every call that's come in, right? And we can, using the vendor, grow or shrink the size of the call center based on the volume of the calls, which you can't do if suddenly everybody is calling the pediatric practice because there's a lot of childhood diarrhea, right? And so, you don't have it, right? If you do it through the call center, then you can deal better with the hills and valleys of volume. We so often still get complaints that I called this number and no one answered. And again, it's because they're calling a subspecialty clinic number where there likely is no one whose job it is to answer the telephone. And so, of course, the telephone goes unanswered. But if you did it through the call center, then someone would answer, and if they couldn't get an immediate call back, they could say, I will call you back when I, reach someone, and they can then, go through our chain of command to figure out, who to call if they can't resolve the issue. The call center is, I think, and it's an organizing strategy. Sorry, Micheline.
Thank you, Mitch. Micheline, are you?
I'm done.
Great, thank you so much. So I think we turn to Ted.
On the HERC program, H&H currently oversees 13 HERC sites, serving about 24,000 daily guests. That's been one reduction of a site since Q3 close. Over 162,000 asylum seekers have been served at our 24/7 arrival center, also operated by H&H. We've committed about $1.5 billion in HERC expenses as of FY24 close on behalf of the city. The city has allocated $1.55 billion in FY24 for H&H's HERC program and $1.72 billion in FY25. The FY25 asylum seeker budget is currently higher than the 24 budget due to OMB's FY25 shelter census forecast and cost trends. So the city's tracking that, and the current census is trending below their 25 forecasts, and the H&H FY25 budget will be updated in future financial plans to reflect any changes in that census. OMB's provided us with revenue to cover all of our committed expenses to date through our MOU with the mayor's office.
Great. Do we have any questions for the team? Any comments? No? Well, thank you very much. I want to just, again, recognize the great work that's happening here and showing up in our financial results. So thank you. So is there any old business or new business from committee members to bring before the committee? There being no further discussion, the meeting is adjourned. Thank you.
Thank you, Frida.
Thank you. Thank you, Dr. Stepping in.
This meeting is no longer being recorded.